Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
That talks about doctors and music and how music, it actually doesn't really address the fact that many doctors are musicians as well, as you know. But it also talks about how music can be used and how it is used. And I can't say that I've used music to address any aspect of medicine that I've done, but I think that what it does is it provides a diversity to your portfolio that is not even recognized because it's just part of you. That's part of you, what makes you do what you do, and it also gives you a balance. It's interesting. There's some vocalists who are physicians who you may not even know about who do that in their off time. And also the background that music plays in while you read, when you are doing preparing to take care of your patients. Sometimes it also helps with your patients who also may be musically inclined, in addition to which you take care of course, I guess the one of the hardest jobs I've ever had is having a countertenor, which is one of the most unique voices there is, who needed a thyroidectomy. And of course, if you need thyroid surgery, then that recurrent laryngeal nerve is the nerve that is involved. And so that's an aspect of music that surgeons have to deal with and other professionals. But I think in the OR, of course, many doctors have their music playing that comforts the anesthesiologists and the surgeons and the whole medical team, so that in many ways music makes the world go round, and it gives that balance and everything else that goes along with it. And any other thoughts about how you as musicians feel that it helps in your health, for example? You know, a lot of pediatricians will have music for their kids and they come in, and most practices don't have music, but most operating rooms have music. And we don't talk about what it does for the patient. We talk about what it does for the medical team. And it probably soothes and prepares things in a way that we usually do not even pay attention to. Mm-hmm. And in this era in which everybody's with the cell phone, using music to give you that other balance is something that can help you be the best that you can be in whatever field you are. It just happens in medicine that it gives that balance as well. Any other thoughts about the role music plays in the health profession?
Well, I think it's extremely interesting, and I'm sure they're just beginning to scratch the surface about this. You know, it's really worth a lot of study for what music can do to, impact your everyday life. In your, Dr. Callender, in your operating rooms, what type of music do you like?
Well, I like Johnny Mathison and his music, and I like music like that. But I like all music, but my preference is easy listening music. That's my preference. But I have some doctors who just love that new stuff, rap and all that stuff. But mine is the easy listening, the classical stuff I've always liked. I've
Well,
never
if
insisted
you're
that it be played in the operating room, but there are many doctors who won't operate without music in the operating
okay,
room.
if you're in the OR and another doctor has hip hop and rap on, do you ask them to turn it off?
No, I would turn it off.
Okay.
As a surgeon, I mean, not in my room. In my room, you play what I like, and if I don't like it, I tell you to take it off. You know, if I'm the surgeon now, as the head surgeon, you have that option. And if anesthesiologist is going to play music that is not going to be compatible with my personality,
Me too.
then I would stop them. Yeah, I would,
Yeah.
because I have to be comfortable as the surgeon. I have to be comfortable, and so that I would not be comfortable with that.
I,
Um,
I have a thought about music. It would seem to me because when I hear music, I kind of get into it. You know, I'm more focused on the music than I am on what I'm doing. I mean, unless it's like elevator music or something like that. You know,
Well, you're a professional musician.
yeah,
That's
but
the difference.
yeah, I have a tendency to, you know, I'm working on something and then music is playing and then I'll focus on the music rather than what I'm doing. I would be distracted.
Yeah, actually, for me, it's just the other way. That music gives me that balance and comfortableness. It's just like, for example, praying before surgery, which I've done, or whenever anything that's complex, whether it's surgery or medicine or anything else, I go to the Lord for support. So, in the similar fashion, music gives that balance that uh, spirituality gives me as well.
yes, my husband just reminded me that when when you go to take an MRI, they'll ask you, what type of music do you want played while you're going through? I guess because you're supposed to be still and they
Yeah,
want
that's
you
right.
to be
Yeah,
relaxed.
that's right. Exactly right. Yeah. John, did you have your hand up, or did you?
Yeah, I want to make two comments. One is a lot of times when you're doing an MRI, they will ask you about the music because the sound that the machine makes, they want to kind of drown it out with something more pleasant.
Yeah,
Uh,
and some people even, yeah.
yeah, that machine makes a horrible sound
Well,
if you have it by itself. The other comment I wanted to make was that what reminded me, John, what John said, and that was I was playing in a band, and the guy playing the piano was so good, and I was playing bass in the band, and I got distracted because of how good he was playing.
interesting. Any other comments on this particular subject, which is uh, usually forgotten about, and not even dealt with, as Darryl had pointed out?
Don't don't forget that music affects the surgeon, but it also affects the patient.
And that's interesting because that's the aspect of it that we tend to forget about, except for neurosurgery, which is one, well, some surgeries are done under local, which means the patient is wide awake, and some of the brain surgeries are done with the patient awake. So when you have the patient awake, and you're right, that's important. And what we sometimes forget is even while we think the patient is asleep, they can hear the music, and we don't appreciate that. So that's a very good point that you bring up, John. Okay, let's go to the next one. Yeah, this is an interesting article about type 2 diabetes. As you know, type 2 diabetes is a diabetes where the pancreas does make insulin, but the body produces antibodies that prevent the insulin from being effective. And so this is a new endoscopic procedure which they do, which interacts with the duodenal mucosa, and that increases the sensitivity to the insulin that previously the body had been insensitive to. And they did this on a number of patients. As you can see, the small volume of patients, and 14, and actually 86%, 12, no longer required insulin. So this is a relatively new type of treatment that really goes back to the new GLP-1 blockers. This is the same kind of principle that the GLP agonists operate on. And so whether this is going to be something that we'll be doing, and you can see that the follow-up was for 24 months, 12 and 24 months. So it's a remarkable accomplishment. So it's going to be interesting to see if this then is going to be a new treatment for type 2 diabetes. And of course, type 2 diabetes is the #1 cause for kidney disease, as you know. So, and of course, this treatment may be simpler than many of the other treatments that we have been giving for type 2 diabetes. And the treatments in general for type 2 diabetes are exercise, diet, and in some instances, insulin.
Dr. Callender, what is a duodenal mucosa?
Duodenal mucosa. The duodenum is the small intestine. The stomach is the first part of the GI tract. Well, you might say the mouth, the esophagus, the stomach. Then comes the first part of the small intestine, which is the duodenum. And the mucosa means the lining, inner lining of the small intestine. There are many studies now that are identifying that if you put substances in the small intestine, you can eliminate the problem that you have with obesity as well as diabetes. And so that's why this treatment of going into the intestine, which is what the duodenum is, the first part of the small intestine, is likely to be something that in the long term will be beneficial and simpler.
So is the
Any other-
ablation?
Ablation means that you destroy the mucosa, the sensitivity. You destroy the intestine. The duodenum has an inside and an outside, and the inside is called the mucosa. And the ablation means that you eliminate the sensitivity of the intestinal mucosa, and that is what is thought to be responsible for the elimination of the it suppresses the appetite and also allows the diabetes to be the insulin resistance, because it is thought that type 2 diabetes is merely a result of insulin resistance, and that insulin resistance is thought to be secondary to antibodies that prevent the insulin from being responsive. And so this treatment would knock out that barrier to the insulin that your body being sensitive to the insulin you produce. That's a complicated answer, but if that doesn't suffice, just let me know and I'll try to make it even simpler.
I think I got it. I'm almost on my way to performing one.
Yeah.
Yeah. Yeah. Be great answer. Great answer. But my question is, if you have type 2 diabetes, but you aren't yet getting insulin, you're just taking pills, would that cure you as well?
Well, it would obviate the necessity for the pills. So it's just a matter of what your preference is, whether you wanted to have this procedure or you want to continue taking the pills.
That's what I'm saying. Okay.
Yeah, it's
Okay.
up to you. Be up to you then. It would be a matter of how simple it is to have a tube go down into your stomach, through your mouth and nose into your stomach, and whether that's uncomfortable to you or not, and whether you just prefer to take the pill.
I think
So,
part of the issue though is that if this is working for 2 years, I mean, you know, if you could satisfy this situation every 2 years, that would be a lot better than having to take insulin every day or something like that. I'm just guessing though.
Well, the question is that has anybody ever had a tube put down their nose or their throat?
Yes, I have.
Mhm. Yeah. Yeah. My husband said he has early on. Not
And
for
so,
not
so
for this, but for something else.
yeah, when I was younger, when I had TB, I had to take a nasogastric tube every morning. And it was a little uncomfortable, but to have it only once every 2 years, as John is suggesting, might be more attractive to some than to others.
So
would the
right now,
catheter be
go ahead.
would the catheter be inserted the same way as they do a colonoscopy?
Well, remember the colonoscopy is from below, from the rectum. So
That was well.
the endoscopy would be from above, through your mouth or your nose.
Mhm.
And if it's a one time every two months, they might I'll give you a little IV injection so you wouldn't even have to remember it.
So is this experimental?
Yes,
Okay.
no question. Only 14 patients.
Oh yeah,
So
yeah,
it was
yeah.
very, very experimental. Yeah.
One question I had is that is it oh geez, if it's the people that have to take insulin, okay, do they take it with a pill or do they have to have an injection?
It varies. Some people only need a pill and some people need injections. Most for type 2, they can do it with pills.
I'll take two.
Betty, you had a comment?
No, no, no.
No.
So,
Okay, let's go to the next one. Fascinating future we have, huh? And then this is something that most of you are aware of, that we now have automated insulin delivery systems. And this is talking about how they overcome the fear of hypoglycemia, which is one of the ways in which people die from diabetes. They get insulin, take too much insulin, and get low blood sugar, which is what hypoglycemia is, low blood sugar. And this low blood sugar can be fatal. And many people die not so much because of the diabetes, but because of the hypoglycemia or low blood sugar. When it gets below 40 or so, then that's damaging to the brain and you go into coma and you may not wake up. But these systems that we have now, insulin pumps that automatically deliver the insulin at depending upon what the blood sugar is, have been very successful in overcoming the side effect of low blood sugar. Uh, uh, you may not know this, but we have some patients who because of the low blood sugars, go into coma, and some never wake up again. And so one of the fears of when the treatment of diabetes is whether or not you give to yourself too much insulin and go into coma and not wake up. And so the automated insulin delivery systems with their ability to detect what the blood sugar is at the same time are decreasing the side effect of a low blood sugar, which is very desirable. Because the two reasons you want to get a pancreas transplant is if your blood sugar cannot be controlled, or if your blood sugar gets too low. So the high or the low in the blood sugar is damaging to the brain and to the body. And so there's these automated insulin delivery systems that also detect the blood sugar are some things that make the management of diabetes easier. I know of some patients who all they do is they have these automated insulin delivery systems, and that they don't even worry about what their blood sugars are because they're automatically detected and also addressed. I don't know if any of you have had any of these automated insulin delivery systems, but it's at the point now that most people who have severe type 2 diabetes or type 1 will have automated insulin delivery systems. There's still some people who still take their insulin by injecting it in their stomachs and other places. But those who have, and this is the other aspect of it that's undesirable, those who have the higher insurance programs will probably be using the automated insulin delivery systems. And those who don't have the resources are often those who are using the insulin injection.
I had a question, Dr. Callender. What is the actual physical device? Is it a device that they carry around with them, or do they have to like go somewhere and plug up to it?
No, you have it inserted into you. You have it, so it becomes part of you. It's not something that in other words, you have this done to you, procedures done, and you have this done, and then after that, the automated insulin delivery then becomes automatic. And you don't do anything except monitor it, and then periodically have your blood sugars checked. And this device actually checks the blood sugar itself.
I have a question. What happens? You have this automatic delivery system, and you have this device inserted. What happens when your diabetes becomes under control due to exercise or good eating habits, etc.?
Well, and then you don't need that anymore.
Do they remove the device or what?
Yeah, sure. Mm-hmm. Yes. John, Darryl?
Yeah, let's see. I just did a search on does the automated insulin delivery system have a malfunction indicator? And I guess there's one system called the Omnipod system that said if any problems are detected, the system will inform you with beeps and on-screen messages occlusion detection, and occlusion is a blockage or interruption in insulin delivery. If the system detects an occlusion, it sounds a hazard alarm and prompts you to deactivate and change your iPod.
Thank you.
I just thought that was interesting.
Yeah,
If the
it is.
thing does malfunction, I know sometimes pacemakers malfunction, but if this system malfunctions, it lets you know.
Yeah, pacemakers have a system that lets you know when your pacemaker is not working properly also.
I had a question though. So this pod system that gets inserted into your body, right? Does it have to be replenished with insulin?
No, it's a no. Well, the whole pump delivery system, and just as you mentioned, if it gets low, then yes, you may have to have it replaced. But that system pretty much runs by itself, and unless there are complications, it pretty much handles your blood sugars.
So I guess my question is it widely used now?
Yes,
Okay.
especially by people who have good insurance.
Oh, okay. So it's costly.
Yeah, and yes, it has a cost. I don't know the exact cost, but I know I had a relative who it took a while before uh, the doctors would put her on that automated insulin delivery system, and a lot of it had to do with the cost of the apparatus. And most of the people that I know who have it are people who are uh, have insurances that are very high cost.
Okay. And I guess that probably answers my question because I'm thinking about my godmother who is 95, but she still has to stick herself with the insulin. But but she also has a pacemaker. So I wondered whether the two could work together at the same time. Maybe that's why they don't.
No, they're independent
Okay.
systems, totally independent systems.
Okay. So then it's probably the cost. Why
Well, it may be a number of things because it also may be I don't know how much insulin she takes, how many times she takes it, once a day, twice a day, three times a day.
I'm not sure
Because if it's only once a day,
if it's
well,
only once a day.
yeah, it may not be much of it. And you get so used to giving yourself insulin that you don't even think twice about it sometimes.
Yeah, but at her age, I don't think she forgets it, but
Yeah, you're right. Those are at
yeah,
her age, you're right, that's a problem.
that's she's had some problems, having to go back and forth to the hospital. So
Oh, yeah.
felt
Yeah.
like if there was a system that would operate, you know,
There
she
is a
could have
system. So
it up.
there
Yeah,
is a system. The only question is whether
can
or not
she
her doctors
afford it?
want, whether the doctors have decided that it's appropriate for her
Okay.
because there are systems. Yeah.
I might mention that to her caregivers and see. If they can.
Yeah, 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 because I have a good friend who uh, had to take a lot of insulin and now uses this system, and he does nothing except as Darryl mentioned, if there's an alarm or something, then something. But for the most part, it's interesting because he's also a sickle cell patient for whom the standard glucose monitors are not sufficient because uh, they have to use fructose and other things. So yes, it does require a special system, and the system does have a cost. And if some insurances may not be willing to pay for it, I'm not sure about that, about which insurances can. I just know that those people who have it are those people who are the more well-to-do people, in contradistinction to those people who are not well-to-do. John Buchanan.
Yes, how large is this unit,
I do not know the answer.
and where would they install it?
I don't know. I don't know the answer to that. And I guess you'd have to talk to your doctor, and they would set you up with the system. Any other questions about it? It's interesting. We had talked last week about some automated insulin delivery systems and how when you fly, they may have caused problems. And this is another article that talks about an insulin pump being an effort to stop this in daylight saving time. Now, there are a number of reasons why people feel that daylight saving time is a menace and should be stopped. But this, people who make insulin pumps, that they have to update their devices every time you have a daylight saving time change. So twice a year, you have to get your insulin pump adjusted. And this is another reason why some people think that daylight saving time increases risk. And there's a litany of reasons. I think we have an article in here that talks about it, but there are a lot of data that suggests that you have people have more heart attacks and more deaths during the daylight saving time and that's a good reason why it should be ended. That alone is a major reason. But we keep talking about it, but we don't really change. What impact does daylight saving time have on you? Anybody have any problem with it?
Or if you have your lights set up on a timer, you have to adjust the timer twice a year, like you said.
Going around the house and changing all your clocks, that's the only thing it bothers. It gets on my nerve. But I do notice that my latest car I purchased in 2019, everything is automated, but the clock does not do daylight savings time. It does not, it stays on standard time. I can't change it to daylight saving time. So
Interesting. Yeah. Okay, but I've heard there's a lot of data that indicates that there are a lot of people who die because of the change. But I have not had any personal experiences with anything like that. Any of you?
If they have all these facts and statistics, so why isn't Congress changing it? What
I
is
can't answer that question.
their
Like I said,
rationale for not changing it?
I do not know. I think I have no idea why we talk about it every year, but nothing happens. I can't answer that question. we'll have to ask the Congress now. But
And
I don't know.
there are a few states, well, I know, or one or two that do not change, so it creates
good.
havoc that when you're traveling to an area to see exactly what time they are, and if they've changed their clocks or not. So United States would be better off if we just not had daylight savings time.
Yeah, that discussion has been held. As you said, why Congress has not acted on it, I can't answer that question. But that's food for thought. And none of the electoral candidates have addressed it. Probably wisely. This is an article that kind of identifies that if you stop your antihypertensives in people who are in nursing homes, or if you decrease the dosage, that this increases the risk of dementia. And they're already there before the dementia. And if you don't continue the antihypertensive medications, that dementia will worsen or the cognitive decline increases. And so this indicates that just because somebody has dementia does not mean you have to forget about their medical problems. On the other hand, it becomes even more important to keep them controlled, whether it's their blood sugar or their blood pressure. And so they certainly have done enough analysis of this to see that, although I can't say it's surprising, but because it's common sense that if you have a hypertensive patient, that should be treated and should be treated regardless of whether they have dementia or not. But here again, this is another study that they did predominantly men and white people. So the women and people of color are left out. But anyway. And it's interesting because it's done in San Francisco, so you'd think they would know better. But anyway. Let's go to the next article, please. This is an article that links, in addition to the other factors that we've already talked about, diabetes and vitamin D deficiency to early dementia risk. We've talked about the other 10 findings that are associated with early dementia. And this then adds these two to the other reasons. Of course, remember again, this just talking about the risk of dementia before 65. Not talking about that after 65, but there's some people who get dementia at 50. And it's talking about that category. And these are, here they itemize all of the 15 issues that are associated with increased dementia, young, occurring before 65. Do you know of many people who have dementia before 65?
I remember when I was taking mom to Iona Senior Services, we had a group, family group, with one family member having memory loss, and one of the guys, his name was John as well. His spouse was, I think, 60, and I mean had full blown Alzheimer's. It was very, very tough, very tough.
Yeah. I had a friend whose wife, who took care of the financial matters, had early dementia, and the way he found out was when the bills were not being paid. And it turned out that she just no longer was able to handle it. So, but anyway, those are the fine. Any of those are surprising to you that associated with early onset
A
dementia?
past co-worker of mine at Centers for Disease Control got it at 43.
Wow. That's the youngest I've heard of. 43 years old. Wow. Wow.
Dr. Callender, it seems like early dementia is a gradual process that gets worse with time. Is that true?
Not really. Most of the early dementia is not picked up until people are really well into it. And I think one of the problems is that nobody thinks about it at 40. And so by the time you realize that it's there. For example, Annette might tell us about her friend her colleague who had it at 43. But one of the things is that if you don't think about it, you can't diagnose it. And if you have somebody who's 40 years old and they start having cognitive decline, dementia, Alzheimer's is probably the disease you least likely think of, and that may be the reason why it's hard to pick up at that age. And so I don't know what when it first manifests itself in that particular patient. So I don't know enough about early onset of dementia to be able to tell you how it starts, because in some cases it seems like it's almost like overnight, whereas others it isn't. Isn't that
I was
any?
working to get her reasonable accommodations as she was getting lower performance ratings over a year's time. Then she got evaluated and was diagnosed.
Like that, huh? Okay. Thank you for sharing. Yeah. Any other thoughts or questions about this variety of dementia that we don't see as often and is as heartbreaking as the other aspect of it?
I was wondering why they changed the name. It used to be early onset.
Yeah. Well, and what are you saying it is now? They say it's before 65. Same.
No, they call
It's
it.
still early onset.
It is
Early dementia, early onset. To me, it's a play on words, but yeah.
young. They call it young onset.
Yeah, well, okay.
I was just
Early on.
what
Early,
the name.
okay, what's in the name? So it's that which occurs before 65. Young onset, early onset, whatever.
I was just surprised that hearing impairment was such a big deal with dementia.
Well, we've been saying that for quite a while now. Visual as well as hearing. Yeah. And that is something that they keep emphasizing, the hearing impairment being a correlate to dementia.
They also call it full-blown dementia.
Well, full-blown dementia. Yeah, that's another play on words, because dementia is dementia. Yeah.
Dr. Callender, is there any, I know that as you age, and this probably has nothing to do with early onset, it's probably just regular dementia. But as you age, you know, your you lose some of your faculties, you forget this, that, and the other, but are there any real signs to look for and just say, yes, this person is starting with dementia?
Yeah, well, I think the recent loss of memory, loss of memory to recent events is probably one of the one of the earliest ways of detecting it. As you age, your memory fades and you don't remember everything. So, but when you have a loss of recent memory, that may be one of the ways to recognize that something's happening. Then, of course, once you have those situations where you get too many things, then it's good to have a neurologist to evaluate you and give you a dementia test and find out. They are talking about the fact that if you have early dementia, there's a way to slow the progression of the dementia. But there is no cure for it. But there's some of the medications they claim slow down the progression of dementia. The anti-amyloid medication that we spoke of a couple of weeks ago. Any other questions about this version of dementia, which we aren't as familiar with? But there was an interesting article that we sent out last week, I think, that talked about differentiating between memory loss that goes with aging and the memory loss that goes along with dementia. So just because you don't remember things as well as you used to doesn't mean that you have dementia. And then, as we know, the different types of dementia, the Alzheimer's, and then there's also the other vascular dementias that are present. Plus, there are dementias that don't impact the ability to swallow, but that only impact the memory, so that the different types of dementia as well. Any other questions about this interesting article and the 15 factors that are associated with that? Okay, let's go to the next article, please. Seems like we're talking a lot about dementia, but then that is a very common issue. But the association with common cardiovascular diseases, atrial fibrillation, heart failure, and coronary artery disease is something that we're recognizing more and more. And so, once again, we announce that prevention is worth a pound of cure, and we think more and more of our emphasis on exercise and proper nutrition being worth a pound of cure and preventing, if possible, the dementia, and as well as the cardiovascular diseases. You know, we keep talking about the amyloid and how it's related to Alzheimer's. There still isn't, we still haven't, you know, there's something called Koch's postulate, which is where you take something and prove that it is actually the cause of it. And with amyloid, we're presuming that that is the cause, but we haven't been able to really satisfy the so-called Koch's postulates and prove that that is actually the cause of the disease. But there's a lot of evidence that is suggestive that it is related to it. And so that's why anti-amyloid medications have been used in its treatment. But of course, more research is needed. But in the meantime, it's important, as you see here, to do those things that go along with improving your cardiovascular health. Physical activity, nicotine avoidance, sleep, good lipid levels, good blood pressure, and good blood glucose levels. The atrial fibrillation, heart failure, CHD is a relatively new part of the puzzle, which we're just recognizing now more than ever. Any additional comments on this article? Okay, let's go to the next one then. This is a question that has loomed large for quite a while. Does the time that you take your blood pressure medicine matter? And so we've had a number of new trials by the European Society of Cardiology, which concludes that whether you take your medication in the morning or at night or both times really doesn't matter. What matters is whether your blood pressure is controlled. And but the time you take it, whether you take it in the morning or in the afternoon, is not really an important issue. So you can take it daytime and nighttime, and theoretically, all of these studies, and you've got hundreds of patients. You notice you're not saying thousands of patients. You're saying hundreds of patients. So that and these are primarily Canadian studies that show no difference. And you see some other articles that we have another article that says the same thing. That it's not whether you take it's not what time you take your medication, but whether or not you take your blood pressure medication and whether your blood pressure is controlled. So which requires that you have to be monitoring the consequence of taking the blood pressure. As we've mentioned many times, most of the hypertensive that we identify in our screening of patients as patients who are already hypertensive but are not taking their medication. And they're not monitoring their blood pressure. So take your medicine. Morning, noon, or night, but take it.
Dr. Callender, would it ever be appropriate when it's come time to take your blood pressure medicine and your blood pressure has been low, that you skip that dose?
I guess the best answer to that question is, what do you mean by low?
Well, let's say that you got your blood pressure pretty well controlled, 125 over 80, and it stays that way for a while. And then you notice that you check the blood pressure one time and it's down to 90 over 60. And it's time for you to take a dose.
I wouldn't take it.
Right, that answers my question. Thank you.
The 90 over 60 is hypotensive, right? So if it were 120, you'd take it. But if it's less than 100, I would advise against it, yes.
Yeah, so that means that you can regulate your doses depend on your.
Now, what that probably means is that when you go to your doctor, you need to let them know that perhaps you need to get the dose of your medication changed so that it's not hypotensive. Because low blood pressure, if it goes too low, that means you're not getting circulation to your organs, and that's not good either. So you just need to let your doctor know that maybe you need to get the rate at which the dose of your medication modified so that you're not hypotensive.
So last question on this. Does that mean that you can regulate your blood pressure medicine depending on the blood pressure results, like going back and forth, going back and forth?
No, I think it means, as I said, my answer would be no. You need to talk to your doctor about that so they can change your dosage. Because otherwise you have a vicious cycle that's unending and it's not good for you. Any other questions about that? That's a very good question because a lot of people have to deal with that, and they sometimes deal with that by deciding that they are the doctor and they're going to monitor and decide how their dosage should be, when they should actually communicate with their doctor and find out what is the proper dosage that allows them to have a blood pressure that is compatible with their good health. And we do know that some people normally have a blood pressure of 95 over 65. And for them, that may be their normal blood pressure. But if that's not your normal blood pressure, then that's a concern. This is an article about how the new guidelines that the European have come up with will affect primary care doctors. And what this hypertension guideline is that they are now considering, as you scroll down, they're considering their blood pressure between 120 and 129 as being okay, whereas the elevated pressure of 120 to 139 as elevated, and 120 to 70 to 134 as. And what this change means that 140 over 90 is high blood pressure. And therefore, it's not acceptable. And so you have to keep your blood pressure around 120. And many studies now are identifying that, particularly in people of color, it's important to keep a lower blood pressure than they used to think. Now, we all know that in the United States, the blood pressures have been decided that if you're over 120, that's what they call borderline hypertension, or and they say more than 130 is hypertension. Whereas and the new studies are identifying that in people of color, it is important to keep the blood pressure around 120, and certainly less than 130, and the diastolic around 80 or under. And that's why studies like this, what becomes important is what percentage of people are people of color that is involved in the study, and whether this applies to all people similarly. And it's not clear in this European study what percentage of people are people of color and what people aren't. And in this day and age, one of the things that is most important is that you monitor your own blood pressure, and you and your doctor keep a record of it and share it with your doctor so they can decide on what is the best treatment for your hypertension. And the biggest problem with the hypertensive issue is that people are not monitoring their blood pressures. And if you're not monitoring your blood pressure, you do not know whether your blood pressure is controlled or not. And this is the reason why people say that the death rate from cardiovascular disease has not changed in the last 10 years. It's because we talk about treating hypertension, but we don't treat it properly. And we're not monitoring it. And this then becomes the real issue with the management of hypertension and the trying to minimize or decrease deaths from cardiovascular disease. You saw that in that article. It says that half of the people who are on medication stop taking the medication after a year. And this then, of course, is what we're talking about, self-medicating, which is dangerous.
Dr. Callender, what are some of the reasons that cause your blood pressure to fluctuate?
Well, some of the reasons are your intake, your nutrition intake, the amount of volume you drink, the types of food you eat and drink. I think that's probably one of the major reasons. The amount of salt intake, the amount of sugar intake. Those are things. All three of those things: the volume, the state of hydration, the sugar, salt. Intake is probably the major reason why you have changes in your blood pressure. And in addition to the types of foods that you eat, whether you are a meat eater or a non-meat eater or eat a lot of vegetables, fruits, those things matter. And that may be the major reason why there's a fluctuation in your blood pressure.
Dr.
There are,
John,
yes,
does stress play a role in blood pressure?
yes. Yeah, stress plays a role in almost everything.
So you have a stressful job that you're working at. That can cause your blood pressure to be out of control.
Yes. So many things that can interfere with your pressure. Stress, of course. Some would argue being Black is a great stress. Actually, that depends on your state of mind, actually, whether it is or not. But stress, yes, the answer, stress. And so we emphasize those things that decrease the stress in your life, whether it's be exercise, meditation, or whatever. Any other questions about this very important topic?
I I know that now that the smartphones, you can get an app for almost everything. So is the app as good as you actually putting something on your arm and testing?
I don't know that. That's a good question. I haven't seen a study that critiques the app versus the blood pressure monitor. And I don't know the answer. That's an interesting question that we'll have to try to get an answer to. I don't know the answer to that question.
Okay.
But a study on that needs to be done.
Mhm.
Yeah.
I saw something pop up on my phone. It's an app that you just put your finger and it'll, take your pressure.
Yeah. That study needs to be done to
Okay.
find out if that will be helpful, because most people do not monitor their pressures. And that's a very good question you ask. I don't know the answer to it, though.
Okay.
This is a study again that talks about timing of blood pressure dosing. Doesn't matter. And it's interesting that most of these studies are done in Canada. but they did 3,000 patients. They again came up with the same result that it doesn't matter the time you take your medication.
But Dr. Callender, you aren't saying that you shouldn't take your blood pressure at the same time every day if you're taking blood pressure. You shouldn't change the time that you.
I think that's a good point. That yeah, I think you should do it. It's probably once or twice a day at the same time. It's a good point. Yeah, you should do it at the same time. Right. And then the other thing is you should write it down so that you can share it with your healthcare provider so that you can take care of it. Darryl?
Yeah, about the question of phone apps and blood pressure monitors. Um, I'm reading on eMedicine Health that there are a few apps, and they're all for Android phones that claim they can measure the user's blood pressure by reading the pulse of the user's finger held against the phone's camera lens. But it says that these phone apps cannot actually check a person's blood pressure. So it's kind of a false claim.
Thank you. Thank you. Okay.
Research is done.
Okay. Okay, let's go to the next one, I guess. And this is an article that says that how you take the blood pressure matters, which it kind of addresses what Darryl was just talking about. That common arm positions like arm and lap or hanging at side can give you an overestimation of the hypertension. And so the standard way of getting the blood pressure, sitting down and mid-cup and heart level, all of those things are important. And so, which kind of goes along with what Darryl just said about the monitors that propose to tell you about your blood pressure. Okay, Darryl, your hands up.
Yeah, I sent in this article because it says the best way to measure it is to have your arm laying on a surface rather than either dangling or not on a surface or hanging down to the side. And I've had a few doctor's offices where they insisted that my arm was resting on a surface. Usually it's the person taking the blood pressure has a cart and they just suggest laying your arm on the cart. Um, the article says that if you don't lay it on a cart, you could get 7 points higher on systolic readings and up to around 4 points higher on the diastolic readings. Um, the last time I was in for my physical, I noticed that my doctor, my blood pressure was okay, but the doctor didn't have my arm resting on a surface. So.
That's interesting. Okay. Well, I think your points are well taken, and I guess at our place, I think it's pretty standard that you do have it, as you mentioned, and not have it dangling.
I would say in the case that you mentioned, it sounds like you are not hypertensive, whereas somebody else who is taking blood pressure medicine and checking their blood pressure on a regular basis, the table might be ideal for that type of person.
Well, no, it's ideal for everyone. It's ideal for what he's saying is that that's the standard, and that should be the standard. And what they're talking about is not the standard. That deviates from the standard. The standard is, as was mentioned in the article, and that's the only way I've ever known it to be done. So that is the standard.
Right. And I'm saying that Darryl doesn't sound like he's hypertensive.
But that has nothing to do with it, whether he sounds like he's hypertensive or not. The real essence is that that standard should be followed for all patients, whether they're hypertensive or not.
And so, as a patient, that's something that you can ask for when they take your blood pressure, or when you take it at home. Just to rest your arm on a table.
Absolutely. Yeah. Let's go to the next article. AI adoption in healthcare. We've had this discussion on many occasions, and it's pretty clear now that AI is a great help to clinicians. And so the more that we accept it as a tool to enhance what we do as clinicians, the better off we are. So to me, it's never an issue of AI alone. It's an issue of AI along with the rest of the healthcare team. And that AI improves significantly the accuracy of what we do as physicians. And to say that we would do it without AI, I think is going backwards. To say it we would do it with AI alone is not moving forward either. I think the best way is for us to take advantage of this new modality and use it together with our clinical skills to have the best we can for all of our patients. And I think that's something that we've been addressing in this group session for the last 6 months. But I don't think you can overstate the fact that AI can help physicians be even better physicians. And that neither should be a standalone. And there's some things that AI can't do, and there's some things that we can't do. But together, it's a tremendous advance in healthcare for the patient to have AI along with the rest of the clinicians' abilities. The ability has been emphasized of the addition that AI with radiation, with laboratory tests, with all aspects of healthcare cycle are helped by AI, artificial intelligence. So it's here to stay. It's not a matter of one replacing the other, but the two working together in the best interest of the patient. Mr. Buchanan.
Yes, Dr. Callender, this artificial intelligence idea reminds me so much of Star Trek with the tricorder. But my concern is at a certain point where you have the robotics and the doctor gets marginalized by the decisions made by the artificial intelligence. What do you think about that?
Well, it just fits into what I just said, that the marginalization should not occur. The two should work together. I would agree with you that you wouldn't want to get to the point where the doctor is marginalized, because I think, for example, we have robotic surgery, which is taking advantage of the fact that the robot does not have a tremor, but the doctor is still a part of it. The doctor is not marginalized. And I think if the two work together, that is ideal. But if one is marginalized, then that defeats the purpose, in my opinion.
My
Yes.
issue is that the AI is like having another member on the team, another hand in the decision making. And so, whereas what you're saying is marginalization, the AI would not be the one making the final answer. I think it would be a team decision. So that way the doctor would never be marginalized, because The AI is just one member of the team.
That's the ideal. That's the ideal. Yeah. Thank you for that comment. Any
Uh,
other?
Yeah,
Yes.
this is a question. I'm sorry, didn't get it in before you switched articles back about the blood pressure. My husband was asking if if you don't have anything to rest your arm on, just holding your arm out straight, is that the same, or do you think it still
I
needs?
think it's not the same.
Say that again.
I don't think it's the same.
Okay, you still need to have it resting on something.
Yes,
Okay.
because otherwise you're using your muscles to do it. That might affect the
I
blood.
used to hold my arm. I thought you used to hold my arm.
Well, he's saying that's not the best. Okay.
No, it's not.
Okay.
Because if you're holding it out, you're using your muscles to do that, which might impact the blood pressure. So
Mhm.
yes, having it on a surface is important.
Okay.
John Buchanan.
Sorry about that. It was still on.
Oh, okay. All right. Any other comment about the blood pressure or the AI? Okay, it's going to be interesting because time is going to tell what's going to really happen. We talk about what is the ideal, and the team aspect, as Mr. Tatum has emphasized. Uh, but you know, it's interesting. You see all these movies in which the robots go wild and AI goes wild, and and so yeah, you have to fear that rather than team approach, you're going to have one marginalizing the other. But let's see what happens. This is an article that talks about the cancer occurring so often in younger people, and that people under 50 are experiencing higher rates than any generation before them. And so it's very frightening. And while it's frightening, it also indicates that we need to be more conscious of what cancer risks are and what we can do to overcome them and negate them. So, and as we look at more items, we find more items that are in the environment that are cancerogenic. And as a consequence, it means that we have to be more careful in our lifestyles. And we can do this by actually paying attention to what we eat, what we drink. And I laughingly say the air we breathe. But as many studies have demonstrated, there are elements we have relatively less control over. The plastics that are around that we drink fluids in, and the pollution that's air pollution, and also the water we drink and other things. So that it seems like every day we find more elements that are cancerogenic in things that we touch or drink. And so what I think the message is that, yes, the data is frightening, but what is more important is to try to learn more about what is improving the outcomes and what is decreasing the outcome. And so the screening procedures and other things that get us to make an earlier diagnosis of disease or prevent it in the first place. And I think that an ounce of prevention is worth a pound of cure is probably one of the most important dictums. And it's one of the things that westernized medicine has lost from easternized medicine. Darryl, your comment.
Yeah, you know, you're talking about cancer with under 50 years old patients. And I
Yes.
was at dinner last night with another couple, and the wife was a OBGYN nurse for 30 years. And she said at the beginning of her career that the the women of childbearing age that she was dealing with, these are typically younger women. 30 years ago, it was very uncommon for them to be overweight, diabetic, and hypertensive, and she says it's very common now. And so, we've got a generation of young women that are heavy and have old folks' diseases. So our population is aging at a very early age, and it's things. It's kind of like the when things happen over time, you don't notice it, but if you just take a look around, our young folks, our children and grandchildren, they aren't as healthy as we were. They're heavier, and they've got all these diseases, and they're more inactive.
Any other comment? Yes, you're so right. Any other comment?
I agree with it. I was with a couple of friends of mine, and we were observing youth and looking at the marching bands and et cetera. And if we know in our day, I hate to say that because it makes me sound ancient of days, but in our days, if you were a cheerleader or a drum major or girl, pom-pom girl or et cetera, most of them were very petite. Now, without this, a lot of girls, and even wearing the short shorts, everybody, it seems like there's so many more overweight young women than there ever have been before. Or they just, if they had them in our age, they did not wear these short shorts or were cheerleaders. They couldn't even be selected for a cheerleader. Now, because of discrimination, they are selected to be cheerleaders and everything else because they said you are discriminating against women of size.
Well spoken. Any other comment?
Yeah, I would blame it on all the processed food they're eating. It's making them huge.
There's a lot of data to support that. A lot of data to support that. Any other comments?
Those young women are eating too many potato chips.
Well, they're talking about processed food. I was in the doctor's office, and I guess I'll call them back today. They were having an old chart of the well-balanced meal, but they also had on their processed meats. And we've learned through study that processed meats are detrimental to you. And I would like to tell them that bologna or sliced turkey or all that kind of stuff is detrimental. But the 3 food groups, the 4 food groups, and they had it up there, but he just hadn't changed or kept up with the studies. But it used to be, get a bologna sandwich, eat hot dogs, and et cetera. And those are the worst things for you. But we haven't come across that yet.
Haven't come across what?
Even they'll give kids hot dogs in a minute. And that's one of the worst meats to give a kid.
No, I'm not understanding, but what are you saying? Your doctor said eat hot dogs?
Well, no, he had a chart, those little figures of food groups of what you should eat.
Mm-hmm.
And one was a processed meat. And I was just wondering, had he realized that times have changed, even sliced bologna or chicken breast or sliced chicken breast that's been processed is bad for you?
Well, I think it's pretty clear that that's accurate. What you're saying is accurate. Whether or not your doctor's adjusted to it or not, I can't answer that.
Also, I think, Carol, aren't you saying that they have not updated these charts?
Yeah.
They certainly need updating because the nutrition that we teach now is far different from what we used to teach because we were pretty ignorant then. We've advanced and learned more. So the chart should be more reflective. You're right. Mm-hmm. As you remember, our doctor who talked about that mentioned that he's teaching his medical students to understand what is proper nutrition. Next article, please. This is a kind of a technical article that says that postmenopausal women actually may have more fat in their breasts. And BMI underreports the amount of fat, whereas you can do a fat analysis, which tells you how much fat is actually in your body. And the BMI underestimates the amount of fat that's in your body. And so they're indicating that excess body fat is the problem, and that therefore you should do a fat analysis rather than a BMI, because the BMI under appreciates the amount of fat you have in your body. And, you know, and we do screenings, we do body fat screenings as well as BMIs, and so that is the more ideal study. And since postmenopausal women have more fat, then they're suggesting that we should do more fat analysis rather than BMIs, although it's important that if you get a mammogram and your breasts are dense, then you do need special studies to differentiate between the cancer and fat. But I don't think that too many people recognize this. So this is just calling attention to the fact that postmenopausally that things are different. Next one, I guess, will be the last one. Oh, yeah, this is yeah, the update of the breast cancer screening guidelines is something that starting at the age of 40 now, which is something that is relative to the fact that Blacks and Hispanic women are in that group more than ever before. And that the mammogram should be done every 2 years. And that I guess the recognition that younger women, particularly Black women with invasive breast cancer, has increased. And so an earlier diagnosis is more likely to result in saving lives. And because for a while it was 50, now it's down to 40. And we recognize that it occurs even earlier, so that if you have a breast lump or some pathology in the breast, you need to have that evaluated regardless of your age. But the fact that breast cancer is increasing among younger women is something to be aware of. The fact that we as people of color have, it's more problematic for us, is something that is of great concern. We talked a lot about the fact that we don't have a good mammogram that is any more comfortable than it has been in the past. And that's something that is we need to work on. And I think somebody thought that maybe we had more women who were radiologists, it would be better. And I would agree that we need to do whatever it takes to make the mammogram as comfortable as possible. But right now, it's still uncomfortable. And I think we'll any other comments or questions on this? This is the last article we'll discuss. No comments? Okay, Dr. Tatum, how are you experiencing your new Doctor of Sacred Music? How you dealing with your new title?
Okay, I got a new title, but I'm not gonna go by it.
Well, we're gonna go by it, so we're gonna go by it.
Well,
Whether you go by it or not.
I'm learning from one of our group sessions. Thank you.
Okay, go ahead now. I think you taught me that, Carol. So, okay, I'll teach it back to you.
Okay, thank you.
Okay, Lynette, thanks for contributing to us, and we're so glad to have you.
Oh, our group is DC Choral Union. We're doing